Good morning.
Just share your screen.
I think I just tried to. It says host disabled participant screen share.
Trying to.
Good morning, everyone. First patient is a 7-year-old male, status was fall, a left both bone forearm fracture. Close reduced and put in a sugar tongue splint. Next patient is an 8-year-old male, status post fall from monkey bars with left both bone forearm fracture. Close reduced and put in a sugar tongue splint. Next is a 7-year-old female, status post fall from monkey bars with the right both bone forearm fracture. Close reduced and put in a sugar tongue splint. Next is an 11-year-old male, status post fall with a left Salter Harris 2 distal radius fracture. Close reduced and put in a sugar tongue splint.
What do you think the chance of growth? What do you think the chance of growth arrest is in that Salter 2?
I believe they're low. I think about 4%.
Yeah, the literature would tell you probably about 2 to 3%, but I think in practicality it's far less than that. I think I've seen 2 in 15 years.
Oh wow.
What would you do with that one if it showed up 5 to 7 days after and it was at some outside hospital and never been touched? So go back to the injury film. Say they just showed up.
Sorry.
Yeah, say they just showed up in the office 5 to 7 days after injury, and they came from out of state, West Virginia somewhere, and were just splinted or put in a brace.
I don't think I would really do much for it. I don't know how good of a reduction you can get 5 days out.
Well, these do heal quickly, but what Dr. Adelson's getting at is there any risk to the growth plate by manipulating it as it starts to heal?
I would imagine that your risk of growth, delay, or arrest would increase if you start manipulating it a few days out from the initial fracture.
Yeah,
right.
exactly. So you're playing a game here with remodeling versus growth arrest. So you're going to look at how much time they have left to remodel. So this kid's only 11. So probably 5 years, right? It's a boy, you said, or a girl?
It's a male.
It's a male, yeah. So you probably have 5 years of growth remaining. So this one, you'd probably choose remodeling over physeal arrest, right? So my guess would be that this kiddo would probably heal this and then completely remodel it within a year or two. I agree with the treatment, though. I think when they show up fresh and it's a brand new fracture and you can reduce it, then I think you reduce it. But some of these show up late and you have to choose between accepting it where it is and accepting remodeling versus alignment. Different story if the kiddo was 15, right? And showed up in your office 5 to 7 days after injury and had 40 degrees of angulation. That one you may choose to reduce that for alignment and take the risk of physeal arrest in somebody who's already within a year of growth remaining.
That's a situation where you might see us actually close, reduce, and pin something when it's that far off, like Dr. Adelson was saying.
I'm sorry, can you repeat that one more time?
Sometimes we might choose to pin that 15-year-old in order to maintain alignment and take the pins out in a couple of weeks and then take our chances with a growth arrest.
Mm-hmm. All right, next patient is a 17-year-old male, status post arm wrestling. I guess he lost because he got his right femoral shaft fracture. He was closed reduced in a coaptation splint.
What else do we need to know from the presentation?
I'm sorry.
What else do we need to know from your presentation?
So he did have a radial nerve palsy. He had weakness with extension of the digits and the wrist, as well as numbness and paresthesia in the dorsum of the hand and radial aspect of the thumb.
Was it weakness?
Yeah, it was weakness. He was able to extend, but very weakly. But it's a neuropraxia, temporary. Most of them resolve on their own. So I don't think there's any intervention to do at this point in time. You can observe it. If it doesn't improve over the next 6 to 8 weeks, then maybe you can think about like an EMG. But I think this is something that will resolve on its own most likely.
Just wanted to start with Dr. Adelson wanting me to share this. There's a Rutgers Ortho Tailgate sponsored by the Orthopedic Research Interest Group. Everyone is welcome, including attendings, residents, and med students. It will be on Saturday, October 9th for the Michigan State game. And we'll start at 9 a.m. at the yellow lots, and we'll send out kind of a message that morning for exact location. Dr. Adelson, you want to add anything else?
Should be a lot of fun. All med student levels are going to be welcome. We'd love some of the residents to try to come out and meet some of our students. Faculty are more than welcome. Should be a good football game. If you're going to get tickets, I think it's tickets on our own, but we have a lot of connections and we'll work on those.
First patient is a 14-year-old male, status post fall 6 months prior with a right scaphoid non-union. We first saw him roughly 4 months after his injury. X-ray showing cystic changes concerning for a delayed union at that time. He was offered surgery, but went to summer camp and then ultimately then fixation about 6 months after his injury. We took some fluoros before we started. That did show a displaced scaphoid fracture, scaphoid waist fracture with no humpback deformity, some cystic changes, and so we proceeded with a right scaphoid percutaneous screw fixation through a polar approach.
You send him to summer camp with no splint or no brace, no cast?
We offered him immobilization. He said, I just it was super painful, and we had some issues kind of expressing the necessity of immobilization and fixation prior to him going to summer camp.
You think if you had immobilized him, could he have a chance of healing?
Maybe, but it was 4 months out at that point already. It was delayed presentation. He got x-rays when it happened and that were negative at that time. He actually injured another finger 2 months after his initial injury. That's where they caught the scaphoid fracture. He was immobilized at that point for a little bit, but I don't think the family quite understood that he needed to be immobilized.
I don't know the answer to this, but at 4 months, percutaneously, you can get enough compression across theoretically a non-union site or delayed union with fibrous tissue.
I think the studies that I read were even at 4 months, doing a percutaneous screw fixation would lessen the time to fibrous union and would, from what I read, would allow him to return to activity quicker than just straight immobilization, even at 4 months or 6 months.
I'm talking versus open and bone graft.
Oh, gotcha.
So there is evidence in kids looking at just percutaneous fixation, and it shows that it does work to create a bony union. I just had a hard time justifying opening this, taking down a non-displaced non-union to try and bone graft it, because it was pretty stable. So it was my choice. There is evidence to go both way. I think you can justify it either way if you wanted to, but in this case, I decided to just do percutaneous. The thought process is that the act of drilling kind of helps take up that non-union and stimulates healing.
I think we do the same thing in a femoral shaft fracture, but I have no idea how it works.
Will you immobilize him now?
We did, we put him in a thumb spica for about 4 weeks and followed with x-rays at that point.
Jeremy, there's one image that you're not showing us, and that's the lateral view. You know, the worry with this fracture is this a proximal or is this a waist fracture? And as you get more proximal, it gets very hard to grab a large piece of that proximal fragment when you go percutaneously. So we don't see where that is, but you're probably on the very edge of that bone. And, you know, I hate going into the wrist joint, but on these, I feel more comfortable going from proximal to distal.
Understood.
That's an open volar approach, Brian.
No, that you would do dorsally.
Dorsally. Okay, got it.
So the first question is, would this heal any other way? I think Charlie asked, would this have healed if you immobilized it, and you never answered the question?
Maybe. I think it's unlikely that it would heal at that point, especially.
What would Rusi say about this, since he has an experience with hundreds of them and he's written about it? What radiographic criteria here would tell you whether this would or would not heal without an operation? Is the most important thing the cystification or the lucency? Is that the most important thing that would predict the non-union? Or would it be sclerosis?
That's sclerosis. I'm honestly not sure.
Okay, the latter. Almost every one of these fractures over time will form that like lucency that you see here. And although it's difficult to see on these films, at least on my computer, I didn't really see any sclerosis. So if you immobilized it long enough and there wasn't sclerosis, and it's just hard for you to see, that is one that would heal, but it takes time. So most people don't do that even at 4 months. But in a 14-year-old, if you gave it time immobilized, it probably would.
Good morning.
So that's the more important finding is sclerosis. And if you saw sclerosis, I think in that particular case, you would open it and probably bone graft because that is unlikely to heal.
Gotcha. Thanks.
Yeah, I mean, I agree. I think that this could heal with immobilization. This family in particular, I did not trust. Someone that shows up to see me in my office with a scaphoid fracture and has, because they have a finger jam, and then tells me basically in the office, hey, we think we're going to end up going to camp, even though you don't recommend it, and just figuring things out and then showing up to see me. I don't know. I don't trust that person.
That fracture was 4 months old when you decided to fix it?
It was probably closer to 5 months because they then had a death in the family and postponed again another month.
Well,
so.
I mean, even with open growth plates, I'm not sure that would have healed without some sort of intervention. And the late, great Joe Slade would certainly support what you just did. He's got papers written on it to be able to bone graft those. I would tell you, though, Dr. Cat is right. If it's more proximal fracture, those are disasters, even if you do bone graft them and everything else. But this one, I think, will do fine, especially with him having open growth plates. Peace.
Yeah, I think they just didn't save the lateral. It was a waist fracture. It wasn't a proximal pull for sure.
This case is an 11-year-old male, stats supposed to fall off a slide with a left both bone forearm fracture. He was neurovascularly intact. A closed reduction was attempted overnight. Did not meet acceptable criteria, so he was taken the next morning for a both bone flexi nails.
What do you think was the issue with that reduction?
There's significant rotation. I think that was probably the main issue.
Did you undo the rotation with your reduction?
No.
Probably that's why it wasn't well reduced.
Fair enough.
Either of the elbow and you have a lateral wrist, something going on there on your reduction film.
Did you do that open?
The flexing nails,
Yes.
we got the radius closed, and then we had to open the ulna.
I feel like a lot of the time with these, the radius is what's difficult to reduce, and sometimes that's easier to reduce open. Then the ulna will spontaneously reduce at that point.
Yeah, we were a little surprised by how it went. But we even made a couple passes through the ulna and didn't want to proceed any further without opening.
What was the entry point for your ulnar pin?
Is the anconeus entry point, kind of a lateral ridge, a little proximal, proximal.
There is evidence that you can go through the olecranon apophysis safely, and you wind up having to take those nails out because they get prominent. Usually, you kind of bend them so they're easy to get out. The anconeus, sometimes it can bother them too, but it's a little safer interval. But either way, it's safe.
This is a 6-year-old female status was fall from monkey bars with a right fracture. Last text was reduced, placed into a sugar tongue splint. This was a 9-year-old male status was fall with a left both bone form fracture that was roughly 3 days old. Multiple attempts at reduction were done at an outside hospital and then sent here for close reduction and placed into a sugar tongue splint. An 18-year-old male status post fall, the right mid-shaft clavicle fracture. He was neurovascularly intact. There was an obvious deformity concerning skin tensing. Decision was made at that point to try closed reduction in the ED. That was successful at reducing the deformity, and he was sent out in a sling squat.
How'd you do it?
Basically, just kind of levered down on the medial fragment and just kind of pulled traction with the arm. This is a 2-year-old male status post fall with a right spiral to shaft fracture. I was neurovascularly intact, placed into a long leg bivalve cast. It's a 65-year-old male status post fall with a right proximal force fracture, neurovascularly intact, including the axillary nerve, and was made non-recurrent.
Morning. First patient is a 5-year-old male, fell from the monkey bars, presenting with left type 2 supracondylar humerus fracture. Patient is neurovascularly intact. Taken to the operating room for closed reduction percutaneous pinning. Next patient.
What type was that, Dan? What type was that?
It was a type 2.
Type 2. Go back to the films. All right, you just don't have any good pre-op X-rays there.
Yeah,
You want to get
a great lateral. It dropped, the posterior cortex did look like it was still intact.
Okay.
Yeah, we don't have great pre-op laterals.
Yeah, so a 2 is 2 pins, a 3 is 3 pins, but that looks good.
Next patient is a 5-year-old female presenting after a fall. She has left type 3 supracondylar humerus fracture. Patient is neurovascularly intact. Taken to the operating room for closed reduction percutaneous pinning.
So why'd you use 3 pins there?
Since this is a type 3 supracondylar.
So go back to the film. Why is that a type 3?
So it's displaced in 2 planes. So in the posterior cortex is not intact.
It's not intact? I bet you it is intact. Usually if it's type 3, it's completely gone. Sometimes we call these a 2.5 or 2.9, but that's not a true type 3.
Thank you.
No, you guys like to classify these as type 3s, but that does not look like a type 3 to me. There's definitely an intact hinge, and you can check that intraoperatively. It doesn't shift much in the coronal plane. you don't get any rotation, and the posterior hinge is intact. A type 3 is when they're separated.
I guess with a 2.5, you can round up to 3 though for 3 pins, right?
Yes.
Well, with the 3, you can still usually reduce it and use the intact posterior hinge to get your reduction. I mean,
Yeah.
Obviously, I don't do a lot of these, but it seems like a 4 is one where you do the reduction maneuver and then it goes anterior and you're off in deflection. So it looks
Those
good.
are the hard, those are the hard ones, Ryan. But I think that this, when that posterior hinge is intact, basically it's just flexion and making sure you correct the varus. And there's no real instability. You're not having to pull traction or trying to realign the condyles. It pretty much does itself. And there's a lower risk of compartment syndrome with those.
Next patient's a 21-year-old female, fell from a piggyback ride, right shaft fracture. Radial nerve was intact. Patient was placed in a coaptation splint. Radial nerve was intact post splinting. Next patient, 16-year-old male, high school football player, was tackled, presented with left simple elbow dislocation. Patient was neurovascularly intact, was reduced, immobilized, and posterior splint.
How did you reduce them, Dan?
So the reduction pretty much consisted of some dental traction, followed by, so I basically grabbed the humerus with one hand and pulled traction in a supinated forearm, and pretty much clunked right back in. It was a pretty easy reduction.
Good, very good. There's other ways to reduce it. Sometimes just putting them prone and having them hold a little weight. They'll just gently slide back in. A lot of ways to do it, but that works fine.
If you were at the game, would you have reduced it on the field?
I think I would rather gotten radiographs before reducing it.
Why?
There could have been an associated fracture, and if there was something I couldn't see, we could end up with
So if he came into the emergency room, he had an associated fracture, what would that be?
The coronoid fracture is probably more likely.
So then would you have taken him to the OR, reduce it, or you would reduce it in the ER?
No, I'd probably still reduce it.
And what's the difference?
If he was 3 years younger, Dan, what would the associated fracture be?
Probably medial condyle.
Yeah. And so Dr. Gadd was asking about reducing it on the field. And Charlie, what's your answer to that question? Would you do it?
Absolutely, I've already done it.
Yeah, me too.
I would too.
I wouldn't hesitate. That you don't know how a dislocation hurts like hell. You're gonna make that person wait 3 hours and swell. If you're on the field as a PG4, if there's an associated fracture, we'll deal with it. But you're trained to reduce that gently. You don't want other people yanking on it. But if you cause an incarceration there, it was gonna happen anyway, or it already had happened at the time of the injury, especially in an elbow. So definitely reduce that.
Also easier a lot of times right away.
Good point. Thank you.
How long will you splint it and normally go back to football if he's playing high school football?
Yeah, so I would at least keep him immobilized for about a week, and then take him out of the immobilization for range of motion. After reduction, he was stable. So, I'm not really too concerned for instability, but we could also consider like extension blocks bracing. Since he is an active high school football player, I don't know that I would have him return to play just right away at that point. But I think it would kind of be a discussion with the patient and family regarding their understanding of the risk. He does seem to be a high-level high school football player and did want to return sooner rather than later.
So what are you basing the return on?
I guess stability. He was stable post-reduction.
Well, that means you can go back tomorrow. What are you going to tell the family and the kid? When can he go back with regard to what criteria? You already said it's stable, but we're not sending him back tomorrow. You already told me he's in a splint for a week, so he can't go back when he's in a splint. So when you take the splint off, what are you going to tell the family when he can go back? When he has no pain, full motion, and 90% of his strength or significant strength? Are you going to use criteria like that?
That does sound reasonable. I'm not sure if there's an actual set of criteria that would have to be.
And that's going to take, and then he's still at risk, but that's going to take time. That's not going to happen in a few weeks. I mean, if anyone goes back in less than a month, that's pretty good. Charlie, when do the college kids go back?
High school kids go back in 4 or 5 weeks.
Right. But how about the college kids?
Same, usually takes them about that much time to get rid of the swelling pain and get strength back.
These people come back at a week and they're incredibly swollen and stiff. And 4 or 5 weeks later, you know, a young guy who gets into rehab, they really turn the corner quickly.
Next patient is an 11-year-old male presenting after a fall from monkey bars with a left bone forearm fracture. Patient was neurovascularly intact, was reduced and placed in a sugar tongue splint. Next patient is a 56-year-old female, fall with a right radius fracture. Neurovascularly intact, was reduced, placed in a sugar tongue splint. Next patient is a 22-year-old male who was involved in an assault, presented with his right index finger metacarpal neck fracture. Patient did present about 2 weeks after the injury. Patient was placed in AP slabs. Next patient is a 56-year-old female presenting after a fall with a left tibial plateau fracture. CAT scan was obtained to further characterize the fracture pattern. So this would be a shaft or two, a lateral depression split. Patient was taken to the operating room for tibial plateau reduction and trauma fixation.
Go back to what's going on in her femur.
Yeah, so there was a cystic change, likely a unicameral bone cyst. She had no history of like prior pain or prior injury.
What's your differential diagnosis there?
I mean, I think the UCB is at the top of the list. It could be like a giant cell as well.
If this patient was 17 years old, what would you think that is? So that could be a non-ossifying fibroma or a fibrous cortical defect. They generally involute as they reach skeletal maturity, so you have to be a little careful in an older patient making that diagnosis, but that's another possibility.
Next patient is an 11-year-old male who was tackled playing soccer with his right non-displaced tibial shaft fracture. Patient was neurovascularly intact. It's a long cast. Next patient is a 56-year-old female presenting after a fall. This left navicular, dorsal navicular avulsion fracture. Patient was placed in a posterior splint.
Yeah, tibia needs to be in a long leg cast.
To prevent any rotational deformity. I mean, it was not displaced in this scenario.
Is your fibula intact?
Fibula is intact.
You think it's going to rotate?
I guess, yeah, it would be pretty unlikely in that scenario. But also it does help control pain for the patient.
With an intact fibula, what deformity would you be concerned about developing?
So it wants to fall into varus.
Think of like your thumbprint or that cast. I don't know.
Thank you.
Good morning. First, we have a right hand dominant 5-year-old male. Steps was fall from monkey bars. It's right radial shaft fracture. Disclosure use placed into a sugar tongue splint. Next, we have a 7-year-old male. Assessed with scrapple fall with his left alternates to distal tibia fracture. Disclosure use placed into a long leg cast.
How old's that fracture?
It was about a week at that point. Next, we have a right hand dominant 74-year-old female. That's was treadmill, fall while walking on the treadmill. She has this right proximal humerus fracture. She's vascular intact. She's not dislocated. She's sent home in a sling.
Why is the humeral head sitting so low there, Jomar?
She has a blood in the joint. She actually is on anticoagulation, so it's probably a pseudo subluxation.
Okay, but what if they weren't on anticoagulants and you weren't terribly worried about blood in the joint? Fracture was a little bit more distal, so it wasn't intracapsular, and the shoulder still looks like that. What's going on?
What he's getting at is they all look like that after about 4 or 5 days. What's going on? I've been asked by junior associates more than once when I first started off this practice, is this fracture, is this joint dislocated?
It's not,
Sometimes they're a lot lower than that even,
Oh,
but they're
yeah.
not dislocated.
They look like this.
And the families will comment, you know, I have kids come in that look like this in their shoulder, they have a big sulcus sign defect and they can see it. So it's,
maybe it's a muscle atrophy.
well, it's not
Not
atrophy, it's
atrophy.
atony. So he gets
Muscle.
muscle stunned, okay? So the deltoid and the rotator cuff are not maintaining the joint. The joint reactive force is knocked out by the pain, the inflammatory response, the neurogenic response.
Next, we have a right hand dominant 84-year-old female. So that's what's ground with fall with this left olecranon fracture. We cite splint in slight extension, and we'll pursue non-operative treatment for this patient. Next is a right hand dominant 21-year-old male. So that's what's ground with fall with this right coronoid fracture. On exam, he was stable to varus valgus. There's no fragments in the joint, and so he was 5 days out from starting to take 4 days out from an actual fall when he presented. So I gave him a sling mobilization for 2 more days just for comfort, and then encouraged early range of motion since he's take it off in the next 2 days.
You think it was an isolated coronoid fracture?
Usually these kind of coronoid fractures come with some sort of dislocation, so or subluxation.
Right, so when you examine him, was he tender over his medial UCL, his lateral UCL?
Yeah, so he's tender.
Right. And usually pretty swollen, right?
Actually, not
so bad.
Not remarkably.
I would consider getting a CAT scan on this in the ER, even if you're going to pursue non-op treatment, because if it's bigger than you recognize and the patient goes to varus later on, it would probably need to be fixed. So I agree, this looks pretty small, but an isolated coronoid fracture, you worry that it's, it could be bigger. I don't know.
Jomar, on the last case, why did you choose non-operative treatment on the 84-year-old?
The studies recently, Duckworth, I think it was in 417 JJ study that it was a randomized control trial that looked at these elderly patients with these isolated olecranon fractures, and they saw they actually had to stop the trial early because the operative group had so many complications after these fractures, and they saw that in the group that they ended up having, they didn't have there were no difference in the outcomes in the small group that they did, kind of comparing operative to non-operative too. So we thought that in this case we would go forward with that.
I think that might be right. The one thing you have to tell people is that they will have inability to extend their elbow fully if this probably forms a fibrous union. But one thing worries me, and that fracture comes a little more distal, and it looks like you have an articular fragment that's depressed. So at some point, I worry about just the stability of the ulnar humeral joint. I think it's more than just a simple 2-part olecranon fracture.
Gotcha. So I probably should put the CAT scan, the CT scan. They were all out of point, but we got 3D reconstructions, and it didn't look like it was markedly depressed in there, but I understand the concern.
They're not going to do great But the question is, are you willing to tackle the complication rate? And I can guarantee that trying to fix that fracture is going to be like, it's not going to be very satisfying. So there's no great answer here, but that the literature certainly supports, offering non-operative treatment.
It looks like a comminuted fracture that you would need to put a plate on. And I don't know, the people that I've treated seem to be pretty happy. They lose a little bit of extension, and it's a small sample size, probably no more than 10 people, but can't recall anyone not happy. I don't think anybody that you would treat surgically who's 84 is going to have full motion, and the 10 or 20 degrees of extension loss is really not a big deal to most people who are 84 years old, even if they're active.
Thank you. Next is a right hand dominant 57-year-old male. Assessed with fall from his bicycle with this little shaft fracture. Notably on exam, he had no motion of the DRJ, no motion of the DRJ, and his elbows demonstrated that we were normal as well. It's placed in a shear tongue splint.
What's going on with his scaphoid?
I think it's not a bad view. I don't know if there's an actual injury there, or yeah, he probably has actually an old scaphoid.
Do you see this?
I think, yeah, I was going to
Yeah,
just say that,
sclerosis.
Dave, that is exactly the point that Dr. Kirschenbaum was making earlier. And this is just a great example of that with the sclerosis. Sorry.
So when you see that sclerosis, that will never heal. When you don't see the sclerosis and you just see the excavation of the bone, that will almost always heal. We don't treat it closed because nobody wants to wait that long, but this is one that won't heal. So yeah, good. It's a good presentation for that.
Next, we have a right hand dominant 34-year-old male. Assessed with lawnmower. Says half of the lawnmower. It's long and ring finger left. Fingertip amps. Station. Didn't have you palpate the bone, but it wasn't visible. I was able to get some soft tissue coverage over that ring finger, and the long finger is well covered. Soft dressing sent home on antibiotics. This is a 38-year-old male assessed with fall stairs. It's left tibial plateau fracture. And a CT scan to really characterize the injury. For this patient, we decided to pursue non-operative management of this fracture. Next is an 83-year-old female assessed with ground fall with this left trimal fracture. She's closure reduced, placed to a short leg splint. This patient's not able to be cleared for ORIF due to critical cervical stenosis. The neurosurgical team was going to operate on this patient, and in fact, the patient was not able to tolerate the induction. She became unstable, and so we pursued non-operative management as well for this patient with a short leg cast.
So how often do you have to see that in the office?
I would say at least early on, at least weekly.
She had neuropathy.
She really wasn't. No, she didn't have like myelopathic sort of presentation. Although she was sort of.
If she did, I would consider treating that with Jones dressing. If you put a cast of myelopathic and that close skin contact, you end up with a full thickness loss, and then you get a problem. That fracture it's already shown itself not displaced.
Yeah, it was as well. I made sure it was well padded for this patient. Next is a 94-year-old male fell upstairs with his left hip intertrachal fracture.
What kind of fracture is that?
It's an intertroch with a subtroch extension, or it's a subtroch. Subtroch.
The fracture is defined how
5 millimeters below the lesser.
Nice. 70 years.
He's taken for a long intramedullary nail. Thank you.
Good morning. First patient is a 58-year-old male, status post MCC with full dislocation, greater tuberosity fracture. He was close reduced, placed in the sling. See, he has a bang card and an equisex lesion. Next is an
Is that going to change your management?
No, it won't change the management for this guy. If he has like recurrent instability, he may need like a procedure in the future to address the bone loss, but it's likely not to change that. This next patient is an 8-year-old female, status post fall with a left tibial shaft fracture. She was made non-weight bearing and placed into a long leg cast.
Morning. First patient's a 4-year-old male, status post fall with a left Montasia fracture as well as a distal radius fracture. They were closed reduced at both sides and placed into a long arm bivalve cast. It's an 8-year-old female, status post fall with a right both forearm fracture. It's closed reduced and placed into a surgery tongue splint.
Going back to that Montasia real quick, we don't have to go back to it. Todd. I know Dr. Ishmael, did he speak to all the residents about trying to transition where we're putting some of these into long arm casts so you get a good mold? You guys talked about that? For a Montasia, because you really need to make sure you have that good posterior mold. Even yours, Todd, there, you could flatten the ulna a little bit more to try to control it. I know that's a little bit more of a lateral displacement. Go back to the injury film. Then an anterior displacement, but the position of the mold really matters here. And then same with both bone forearm fractures. The margin of safety in putting a bivalve long arm cast on as opposed to a posterior splint, really getting that good mold and trying to learning to supinate appropriately. You get a lot more control in a long arm cast. Some of you expressed interest in doing that and seen that in places where you went to medical school. Joe Marr, John, did you guys kind of see that where you guys went to med school? Jeremy, really doing long arm cast for both bones? Sure. Yeah. Yeah, and I'll we can talk about this in the PEDS meeting afterwards, but I think in general, that might be the way to go. And a fracture like this might benefit from a bivalve long arm cast. And if they're really swollen, you could, certainly take that into consideration. We don't want to induce a compartment syndrome, but it probably gives you better control for Montasias and for forearms.
For the forearms, I know it's what you're saying, they dislike some of the bivalve long arms just because for some of the more tricky reductions.
Yeah.
Just in the middle of the night with the number of hands you have, there's usually just you.
Sure.
Like they were just struggling, having to redo several casts because they just weren't getting the reduction they wanted with the cast.
It's valuable time if they are patients who take cancer off.
Understood. In the right context, yeah. So I think that's something we could consider, and we should talk about those issues. Okay, good.
Is a 12-year-old female who jammed her finger playing soccer and has a left thumb proximal phalanx Salter Harris 2 fracture. She was closed reduced and placed into a thumboslicus splint. Is a 3-year-old male, status post fall with a non-displaced left tibial shaft fracture. It's placed into a long leg bivalve cast. It's an 11-year-old female, status post fall with a Salter Harris 2 ankle fracture.
disclosure induced and placed into a long bivalve cast.
Is the syndesmosis tender there, Todd?
He was kind of globally tender. It's hard to say specifically.
Yeah, you gotta think about that slightly. So you gotta look carefully at your x-rays. I think it's fine. I really have no worries. And the force line probably goes, to the upper part anyway, but it's really technically Weber C. So you gotta think about it.
The 38-year-old male who was hit by a wave at the beach and sustained a left AC separation. He's given a sling.
The emergency room called you for that?
Is a 45-year-old male, status post fall, drunk, fell down the stairs, sustained his left proximal humerus fracture dislocation. Exposure reduced, placed into a sling. 37-year-old male, status post fall from a ladder with a type 1 open right distal radius fracture. He was initially had a closed reduction attempt and then was taken to the operating room for right distal radius IMD and ORIF.
Chance of ulnar styloid being a problem.
Low. Like, he might have pain for a long time there, but it shouldn't. The size of it shouldn't cause any instability.
This is not the same case from last week, right?
No.
Because the one where we talked about the plate and its position.
Just articular fluid.
So what would be the concern with that plate?
That you could have irritation of your flexor tendons.
And with irritation, what's the more serious issue?
Rupture.
Yep. There are several other plate options that will try to avoid that even with such a distal fracture.
So what's the SON classification for the position of that plate?
So that would be a 1, I think, in my opinion.
Well, actually, I think it's a 2.
I think it's a 2.
Well, I think it's in the watershed and it's well below the line parallel to the shaft. If you look at the volar tip of that radius, I mean, it's in a bad position. I mean, you have to treat the fracture, and if you only have this plate, then you have to use it. But I think this is one you might plan to take out in the future. And what was the answer to the ulnar styloid? What do you do with the ulnar styloid after you fix the radius?
In this scenario, nothing.
Well, is there any scenario that you would do something?
Yeah, if it was a larger piece that went more into the base of the styloid.
So if you really thought there was instability and it was at the base and included the entire TFCC, now this does look fairly proximal, but you can test that afterwards. So the majority of them, if it does not involve it, the results of whether you fix it or you don't fix it are the same.
So Kirschbaum, how do you test it?
Well, some people feel comfortable clinically testing it by rotating it and doing a shuck test and comparing it to the other side, which you test ahead of time. But I think that in the majority of cases, once you stabilize the radius, these tend to do well, even the ones that are at the base.
The 54-year-old female Sassos NBC with a left finger proximal phalanx space fracture extended to the shaft. She was closure reduced, body taped and placed into an extension block and splint. Is a 90-year-old male Sassos fall with a left greater trochanter fracture. He had no pain with log roll and was able to straight leg raise and ambulate. For that reason, it was felt that he did not need an MRI and was treated with protective.
Todd, when you see the patient with the finger fracture in the office, what are you going to make your decision whether to operate on this patient or not on?
Yeah, so I base it on angulation of the fracture. I can't, it's hard to tell for sure, but I think there is an intra-articular component here. And I would want to make sure that it's not displaced at the articular surface. For her, she also is diabetic and has an A1C of 11%. And that makes me even more skeptical to operate on her. So I've definitely want to follow this very closely.
If you're going to treat it closed, the only thing I would say, I mean, you don't want the articular surface to be displaced significantly, but these are almost always could be reduced, is an extension block splint is really not what I would use for something like this. You really want a static splint to keep the MP joint flexed. If you do not flex the MP joint and allow it to extend, you're going to get that deformity, which probably isn't a big deal in this person. But if you really want to maintain it in a younger active person and you don't want to get that kind of claw deformity, you really have to keep the MP joint flexed for a few weeks.
Okay.
And if you did decide to operate, would you look to do ORIF or would you look to do PIN?
I would look to do pins as minimally invasive as possible for her.
I think that's exactly right. And as you look more distal, it looks like that fracture line extends. So, you know, I've certainly been there where I've opened a fracture and realized it's much more complicated. And then you can get into a whole host of problems. So closed reduction pinning, if your rotation or your angulation is off, is probably the way to go.
This is a 65-year-old female with cognitive delay, minimally ambulatory, fell and has a right tibial spine fracture. It's non-displaced. She was placed into bulking the immobilizer. The 40-year-old male status host motorcycle collision with an open right tibia fracture. Fibula is intact. He was taken for a right tibia, IMD, and IMAL. It's a 44-year-old male who sustained a motorcycle collision and had a left great toe IP joint dislocation that was open and a closed fourth toe PIP joint dislocation. They were both reduced and he was made weight bearing a salary and a Harsel shoe. It's a 68-year-old female who sustained MVC versus tree and had a right acetabulum, right type 1 open distal radius, left spinal ankle fracture. This is the X-ray in the trauma bag showing the posterior wall fracture dislocation, the right distal radius fracture, the left ankle bimal fracture, was closed reduced and taken for a CT scan, confirming the reduction. The right distal radius was initially closed reduced, placed into a surgical splint, and the left ankle was also splinted. That day they were taken for a right acetabulum or IF. A right distal radius, IMD, and ORIF. And a right ankle ORF.
Brooklyn's 9-year-old male fell off trampoline with vocal forearm fracture. He was closed reduced and placed in sugar tongue splint. Had follow-up in 11 days, showed some persistent fracture displacement. Patient was then placed into a cast. At 18 days, it showed further displacement of the fracture, and at this juncture, it was decided to perform surgery. Patient was taken for bulk bone open reduction, percutaneous pinning. These are post-op X-rays on post-op day 7.
Did you open both bones, John?
Yeah, both. Adequate alignment.
You can take the hardware out.
You can take it out in about 9-12 months. I'm gonna keep it in.
Yeah, that Electron pin doesn't last that long usually. Usually by 12 weeks, they've got a big bursa over the Electron. You wind up taking it out, you know, in response to that. And usually you're healed well enough when you have to take it out that it's not an issue. It often goes earlier though.
14-year-old male twisted his ankle during an ATV accident about 3 weeks ago, showing a left trimal equivalent fracture. Patient taken to the operating room for a left ankle ORIF.
Why'd you place this in osmosis group?
Stress positive, and fortunately the floor wasn't safe. It's fine.
Why 3 weeks out? What was the delay?
I was seen the outside hospital and then.
What was that?
It was seen in an outside hospital and then showed up in the office. At that point, it was booked for surgery.
Okay.
So 12-year-old female with 1 month of left hip pain and 1 week of right hip pain with bilateral skiffy. 7 candidate screws were used bilaterally, with center, femoral head, hip pain lateral. It's the left side. It's the right side. 14-year-old male was tackled playing football, left both bone forearm fracture. Closed reduced, placed in a sugar tonic splint, over due to persistent malalignment. Decided to take the patient to the operating room. Patient was taken for a ORPP of the radius and ulnar with 2 flexing ankles.
No, open the radius. Did it open the ulna?
Yeah, we opened both. It was difficult to try to get it closed.
Radius was split.
The 13-year-old male playing soccer, a left both forearm fracture. Closed reduced, placed in sugar tongue splint. The 5-year-old male fell on the elbow with a right radial neck fracture. Patient was placed in a posterior splint. Follow up in 1 week.
What's acceptable alignment, John? Yeah, even up to 45, they can remodel in a younger kid. But you got to keep a close eye on these. And, you know, a malunion that doesn't rotate well can be a problem. So what might you do to evaluate the motion here?
You can get a motion, you can prono and supinate, flexion extension.
Do that, but you got to inject the joint to do that. Okay, or do it under sedation.
Yeah, no block motion. I male, I found his wrist with left open forearm fracture. This was placed in a bivalve short arm cast. 41-year-old male, vehicle accident, left scapula fracture, displaced. Patient was placed in a sling, early range of motion, extubated. 4-year-old male, he fell on his wrist while running with left distal 1/3 radial shaft fracture. He was seen at an outside institution about 2 days ago, placed in a with the last sugar tongue splint. Splint was taken down and then placed in a plaster sugar tongue splint. 13-year-old male, he fell off his bike 2 weeks prior with bilateral both bone forearm fractures. Patient was taken to the operating room for open reduction percutaneous pinning. There's a 2 flexing nail in the radius and 1/5 in the ulna. And then the left side, the plaster cast was taken down and placed in a fiberglass short arm cast.
Only operate on the one side.
Just the right side, yeah.
The other side did not displace. And you could ask yourself, if you're taking a trip to the OR, is it worth it? But that looks too good.
So a female fell on the elbow with type 4 supracondylar humerus fracture. Patient was nerve intact, pain came with strong radial pulse. Patient was initially placed in a posterior splint and taken to the operating room for CRPP with 3 lateral pins. The 83-year-old male, mechanical fall from ground level with type 2 dense fracture. He had no neurodeficits, negative Hoffman's, placed in a hard collar. 81-year-old female fell with L2 compression fracture. Midway brain is tolerated and followed for 2 weeks. 14-year-old male fell on a wrist while playing soccer with Saltaris 2 distal radius fracture. Was closed, reduced, and placed in a sugar tongue splint. follow-up closely in a week. 83-year-old male fell onto his knee with a right displaced patella fracture. Patient was able to straight leg raise against gravity, placing a bulky Jones knee mobilizer with bearing tolerated extension for 2 weeks. 9-year-old female stubbed her toe, a left fifth toe, left proximal phalanx shaft fracture. Patient was placed in a Hartzell shoe, followed in 2 weeks.
It's a 68-year-old female status skull with right bimal ankle equivalent fractures just initially seen in urgent care. She was splinted and sent out with wavering as tolerated. Patients couldn't ambulate, so she came to the office. Patient was indicated for clinical surgery with the stress view of the ankle was open on the medial side, and with it ORIF, another stress test after placing lateral plate show still widening on the medial side, so we decided to add syndesmotic screw.
First patient is a 79-year-old female who had a fall back in May, was initially treated with a Sarmiento brace by an outside physician, and referred to one of the physicians over here for a left humeral shaft non-union. She's taking the OR for left humerus ORF with compression plating. Next is a 42-year-old male who's fallen down several steps with his right Anesthesia / segmental ulnar fracture. It was provisionally splinted in the ER, stayed the following day for an ulna ORF. Next is a 79-year-old male who stand and fall at home with his left femoral neck fracture. The patient is a minimal household ambulator with a walker, so otherwise wheelchair bound with frequent falls. Has history of severe aortic stenosis, as well as Parkinson's dementia. I was taken the next day after cardiac clearance for left hip cannulated screws.
What type of anesthesia did you do?
So we ended up doing general. It was a big debate back and forth. They actually debated whether they wanted to do a spinal or not. They were worried about his drop in his blood pressure. Which is
So generally, aortic stenosis is a contraindication to spinal, right?
Yeah.
So that's the, yeah.
I can't believe they debated.
Yeah, they never debate that.
So anesthesia did not debate it. Cardiac.
Well, then they don't know.
Anesthesia won't do it.
They
Yeah,
wouldn't
that's
do
the
it.
point, and everyone, you should know
You
that.
could do a regional, I've done these under regional, and they do pretty well. Regional sedation, you're quick, you're placing those screws.
We do a fasciolitis block mark or femoral block.
Fasciolitis.
Yeah.
That's what are they doing those now? Where was this case done?
Who's that here? So that was the debate whether or not they're gonna do fasciolitis or just do general, and we actually had one of the cardiac anesthesiologists end up just doing.
Fasciolitis gets your LFCN, your femoral nerve, works very well for this.
Yeah, I think you have to be patient, Tommy, when you, the ones I've done, it takes a while to
You got them
set in.
set? Yeah.
So you can't say, oh, he's got a lot of pain, put him to sleep. You know, they should do that case even before you sort of get on the fracture table. And by the time you do that and put them in the fracture table, and then gently, then it takes hold. Done probably 10 or 15 of them that way. And, you know, 25 years ago, 15 years ago, they didn't do that here. And then you had general anesthesia, sometimes difficulty getting off ventilation, et cetera.
Yeah.
I think with our hip fracture pathway, aren't we, or isn't anesthesia evaluating some of these patients and giving them an fasciitis block just for pain control prior to surgery?
They,
mean like when they're in the ER?
yeah, they're not,
Yeah.
this pathway, it doesn't seem to really have a.
We're trying to get them clear to get them operating on day one rather
This was a case that we ended up waiting around. It wasn't until about 4 or 5 o'clock in the afternoon before cards. Anesthesia evaluated him and said they wanted cards to do this severe aortic stenosis, and they had an echo from recently, only in July, showing that the wall dysfunction and aortic stenosis. So they wanted cards clearance. Cards didn't see them until 3 o'clock in the afternoon. Next is 77-year-old female who had a fall home with this displaced right coronal neck fracture. This is a lady with ovarian, so has a history of ovarian cancer with recurrence recently on chemotherapy. Initially presented with a white count of 0.4 and platelets of 30,000. She was optimized eventually after 3 or 4 days on Neupogen, where white count was finally deemed improved enough. Over 1.5, and platelets were over 100,000. We took the ER for right. Next is a 20-year-old male who's in a motorcycle crash with his left open femur fracture, significant bone loss, as well as an ACL tear that we found. Here's the capsule fracture. I was taken for just femur ORF and antibiotic cement spacer for masculine.
That little mini frag plate spanning the masculine.
No, that mini frag plate would have been intramedullary, but there was no bone on the top of that plate.
Yeah.
So it was just just giving us provisional hold of the medial condyle to the shaft.
Why you pass the
What?
why pass the other implant?
Yeah, just so that we could get the fragments of the lateral condyle, which was about 4 different pieces.
Yeah.
3 different pieces, and the trochlea was actually a separate piece that we found somewhere in the thigh. And then we were able to line, you can see these little 2-0 screws that are lining those pieces.
We can't see anything.
Oh, sorry. You see the little mini frag pieces, screws here, and then there's actually 2 going this way across. They're behind these screws that are kind of holding those fragments together. And then we were able to get the larger implant on.
Dr. Butler, Dr. Pushland, I know you're listening. How much do you worry about a mescalate technique that's intra-articular?
So it's not actually intra-articular. There's the articular surface lined up. The mescalate would be kind of up to the shaft. You can see this is.
But it's bathed in joint fluid, so the worry is union and.
This is the cement.
Well, when are you going to put your masculine?
About 6 or 7 weeks.
So by that time, your joint surface should be completely healed. I don't know that it will be bathed in joint fluid.
At that point, yeah.
Yeah.
Joint sealed off.
Yeah,
I'm just wondering if it works at this level.
I did talk to Dr. Swan. Basically, we found the ACL was attached to a little basically footprint. There was just a portable chip that was not repairable. So I talked to Dr. Swan, and the concern is that hey, you have no place to put the bone tunnels right now. Because you got no bone there, and he's
Oh, you're worried about
That knee's going to be stiff or unstable.
I think he's stiff.
There you go. So don't worry about the ACL.
Yeah.
I'll eat my hat if he needs an ACL reconstruction.
He's also going to be spending some time in our fine correctional facility that he stole motorcycle that he crashed.
Oh. Show us his DFR in 2 years.
Yeah, I don't think, Charlie, you and I have ever seen one that was unstable after.
After that?
Never after that. You're lucky.
You're lucky it gets 90 degrees of flexion.
Can I ask you guys a question real quick?